Hi, good morning, everybody. This is Soumitra again. Today we see that around say 15 participants are online till now. But in any case, what we'll do is that we'll start the session, and while we'll be doing the recaps, I will hope that the rest of the participants will join us. So today, as we discussed in the last session, we'll pick up two topics in the health sector. One is HIV/AIDS and then tuberculosis. So as I mentioned last time that I thought that it would be good if we split the health session in two sessions. The first sessions we have already discussed last time, and today we will be discussing on two particular issues of HIV/AIDS and tuberculosis. So before that, as usually, what we'll do is that we'll do a quick recap of the last session so that that is refreshed in our mind. So as we discussed that, if we look at the scenario, it was not a very pleasant scenario. Every fifth young child in the world lives in India. Every second young child in India is malnourished. 3 out of 4 young children in India are anemic. Every second newborn in India is at risk of reduced learning capacity due to iodine deficiency. Malnutrition limits development potential and active learning capacity of the child. Again, I mean, this is in the morning. The first thing to be discussed, definitely it's not pleasant, but at the same time, that's the reality we are working on. So as CSR managers and CSR leaders, we need to really, keep it in our mind that CSR is not always a very romantic and, something, doing good philanthropy or charity, because, there are so many challenges to address, socially, economically, health-wise, education-wise, livelihood-wise, and we have that great responsibility to address all these, challenges through the resources what we are supposed to, spare for these particular CSR activities through the organizations we are working with. Again, looking at the nutritional status, you can see that India is really in bad situation. As per 2005 data, India has 20% children are wasting. Wasting, as I said, that one of the indicators, one of the parameters rather, we use to measure malnutrition. Again, if you look at the bar charts on the right hand side, if you see that we have a very persistent high undernutrition rate through the years. State-wise, we see that MP is really having the worst situation, followed by Jharkhand and Bihar and Meghalaya, Chhattisgarh and all these states. Then we discussed about the cause of malnutrition. What is this? Okay. The cause of malnutrition, that is the UNICEF conceptual framework. Again, as we said, that malnutrition is a manifestation of many other causes. So these causes, if we see, and if we really, as we discussed last time, that if we really want to address some of these manifestations, then we'll have to find out what is the root cause of this particular problem. And these causes are very dynamic causes, and different factors actually contribute to that particular manifestation. So we see that there could be the root causes might be lack of resources, it might be the economic structure, but again it is not only poverty, financial poverty or economic poverty. There are the belief factors, there are cultural factors there. We talked about the inter and intra household poverty, intra and inter household food security. So we saw it is not only poverty, that one poor family is malnourished because they cannot afford to have good nutritious food, but within a family, even that family as a whole is not in that kind of poverty situation. We see gender-wise there is a kind of discrimination within the family, and we see distinct difference between the nutritional status between male and female candidates within a particular family, even if it is the richest family in the world. So that is the kind of, there are several, as I said, that there are multiple factors contributing to these manifestations. What we see that it is not only the food security alone. With that, we'll have to see that what kind of maternal and child care facilities are there, what kind of health services are there, what kind of environmental situation is there. Then that contributes to on one side inadequate dietary intake, and on the other hand we see that there's a infection, a lot of infection it causes, and that leads to malnutrition. So that when we are working in a particular area, and if we see that, as we see that malnutrition is rampant in Indian situation, and it is prevalent in all the locations across different strata of the society. So definitely what we need to do, if we really want to see or develop a kind of impactful program, then we'll have to get through the causes and try to see that what are the root causes, and try to see that how we can have a multi-pronged approach to address the issue of malnutrition. Again, in this, I will not get into detail. We discussed about the life cycle approach. So we said that it is not about the child, but it is intergenerational. So that if we really want to see, and we saw that the under 5 malnutrition status is quite stubborn. It is not changing through the years so much. It's because it is intergenerational. So that if we don't have a healthy mother, we cannot have a healthy child. If we don't have a healthy, girl child, we cannot have a healthy mother. So that if we really want to address that, then we'll have to have a life cycle approach. So we'll have to cover infant, children, newborn. At the same time, before the child is born, we'll have to cover the mother, and even before that mother is that particular woman becomes mother, we'll have to actually cover our services through the adolescence period. So this is a kind of life cycle approach we'll have to take, and some of the indicators will change in long term. So we cannot expect in some of the cases, especially for under 5 malnutrition cases, the changes immediately will happen. It takes one generation to see the impact. So that it's a long-term challenge, and it's really one of the most difficult challenges what we are facing in India. Now we saw that there are different kind of nutritional interventions or programs, sponsored by the government, and we discussed about ICDS, Integrated Child Development Services Scheme, National Prophylaxis Program for Control of Nutritional Anemia, National Prophylaxis Program for Control of Vitamin A Deficiency, Midday Meal Program, National Control of Iodine Deficiency Disorder. Though Midday Meal Program is not a nutritional program, but still it has nutritional input, so we thought that we will also include that in this list. Again, we need to understand that all these health sector initiatives and nutritional initiatives are now converged within the framework of NRHM, National Rural Health Mission. So in that we see that actually there are different components of the program, might be from different ministries, different departments are actually driving those particular components of the programs, but NRHM is the umbrella of program through what it is getting coordinated and it is converged to. Now we talked about anemia. We saw that anemia causes a lot of problems. It is not only reduced physical development, impaired sexual and reproductive developments, reduced cognitive developments. So that, and we also discussed that it is on an average, if we see that the hemoglobin rate is below 8, that should be a kind of sign of severe anemia across all the age groups. We also discussed about the prevalence of anemia. We saw that we are actually behind of Nepal, Pakistan, Sri Lanka in terms of anemia. We have 74.3% population who are anemic, at different levels, at different grades, but 74.3% of our population are actually anemic. That means many of us, most of us also are anemic, right? Then we saw that through different age groups, we see that up to 79%. It might be in some age groups it's a little lower, but we see it's on an average, it is more than 50% of our, around say 50 to 60% of our populations are anemic through across the age groups. Now, in terms of maternal health, we saw that, we are in a really grave situation as it is about anemia or other malnutritions. This is one of the key health issues what we thought that we should discuss, and through our health programs probably we should really consider this to be addressed, because 19% of the total mortality rate, maternal mortality, portion of the global, we are contributing 90% of the global maternal mortality. Alone, India and Sub-Saharan Africa is contributing 85%, and we are contributing 19%. So this is something really we saw that, one of the really a striking, health problem of India. Then we discussed about different causes of under 5 child deaths, and we see that globally more than 1/3 of child deaths are attributed to undernutrition, and most of these deaths can be prevented if we can address the nutritional issues, right? So that is what we discussed. Most common causes of maternal death in India, 37%. In this case is hemorrhage, and then it followed by 34%. It is a miscellaneous different kind of causes. Then we have 11% sepsis and different, but the key takeaway from this discussion was that, most of the things are preventable if we have little bit of preventive health care. And we saw that, it is not only once, as we discussed that, in our country, what happens is that we start taking maternal care after a woman becomes mother. But actually the care should be taken much before that, at adolescent age. Even it should start from the child age, so that we should have a life cycle approach to address all these issues. Then we discussed about the coverage and targets for RMNCH plus A, as we discussed that it is adolescence. It's an emphasis. It has an emphasis on adolescence health. So broadly we covered malnutrition, we covered a little bit of reproductive health, we covered child health, and we saw that different aspects, how it is contributing to the kind of grave situation we are sitting on in India at this point of time. And if we see the total malnutrition burden or total mortality, maternal mortality rate, or under 5 mortality rate, under 5 malnutrition rate, we are contributing a huge portion to the global scenario. So definitely it's a paradox we discussed that on one side India is actually becoming an economic power. We are actually doing pretty well in terms of economic development, but on the other hand we see that actually we are having a very, very grave situation in terms of health. So if we are talking about inclusive growth, then definitely we'll have to see that whether this kind of imbalance can be addressed through our corporate social responsibility program. So corporate social responsibility, when we are talking about, definitely it should be more objective, and we need to know that what actually we want to really achieve through these programs, right? And sometimes we need to see that it is not that we will have standalone programs, but we should have some kind of programs what has some kind of synergy with the situation and synergy of the national level programs or the government programs, so that we can create a larger impact in the society. With that, we'll start today's topic, that is HIV/AIDS, the first topic. Now, as most of us, we now understand because of widespread communication programs and all, that this is AIDS is acquired immune deficiency syndrome. This is a group of potentially life life-threatening condition caused a result of progressive decrease in body's immunity consequent to infection by HIV, that means human immune deficiency virus. So that HIV causes HIV is a virus what infects human being, and that might cause AIDS, that is acquired immune deficiency syndrome. So that HIV and AIDS are two different terms. One is that the virus which infects human body, and the AIDS is the condition of the body which might be caused by HIV. So it is that all HIV infections, what we need to understand as any other infections, all infections are not in that condition of AIDS, so that it might be in a dormant situation, so that all HIV patients, HIV infected people don't have to show the symptom of AIDS, right? It might be in a kind of dormant situation, or it might develop into a AIDS condition. So that is why it is more dangerous, so that unless and until that kind of symptom is visible, then we don't know really that who are really infected. Even that person in a dormant situation for many years, that person might not know that they are infected by HIV. Now, what are the roots? As we know, most of us, that it might be unprotected sexual intercourse with an infected partner. It might be vertical transmission from mother to child, and it might be injecting drug use, or it might be through needle exchange. It might be during blood transfusion if the infected the syringe or the needle used for the infected person is not changed, and if the same needle is used for another person, through the needle it might get transmitted. Now, one thing we need to understand, that this is really scary sometimes, that the infect transmitted through different routes. But one thing we need to understand, that AIDS virus, HIV, is one of the most vulnerable viruses. So it is not that one needle is immediately given to the other body. If it takes some time, even if it gets some time, the virus will actually, in a normal temperature, the virus will not live long. So sometimes what we see is that it is really scary, but sometimes we get a lot of phobia, because sometimes we get the rumors that some people are actually spreading HIV through needles in the theaters and all these buses and all these public places and all these things. It's really difficult, because it's so a vulnerable virus that in normal temperature also it cannot actually live long. Now, if we see the transmission routes, how it gets transmitted through sexual routes, 85% of people who are infected, they get it through sexual routes. 2.39% of the people who are infected, they get it from injecting drug use. 2% are blood and blood products. 3.6% are perinatal, that is from mother to child, and through other routes it might be 6.01%. So that we see that the highest transmitting route is the sexual route. So that through unprotected sex, 85% of the infected people, they get it through unprotected sex. We'll get into a little more discussion about that. Now, through different tests, the diagnosis is done. The name of the, we'll not get into detail of this, name of the tests are ELISA tests, Western blot tests, rapid HIV tests. So these are the tests, generally is done, but these tests are done with consent of a person. So we have a very strong protocol for HIV tests, and even for treatment, for counseling of HIV AIDS, it's a very strong protocol we maintain, because there is a lot of requirement of confidentiality. So confidentiality is very important. So without consent of an individual, nobody, even the government, cannot actually do the test and do anything else with a particular person. Now, as we are discussing about different transmitting routes, if you see that the exposure route blood transfusion, the efficiency of transmission is 90 to 95%. contribution to total number of cases is only 5%. That means though blood transfusion is effective, very effective media for this infection, but only 5% of the population, they get infected by blood transfusion. So in this list, if you see, I'm not getting into all the things, only you just look at sexual intercourse. The efficiency is only 0.1 to 1%. That means it's very, very low efficient media. But 75% of population, who are infected, they get through sexual intercourse. The only thing what we need to understand that this is a behavioral aspect. This is something is not through the health system that somebody used infected blood or somebody used infected needle or something else, or it is not even through mother to child. Only it is a particular person's behavior or a group of persons' behavior, unprotected sex, that causes the transmission at the highest level. Though that transmission media is the least, one of the least, efficient media. So if we really now need to understand that, how to prevent the spread of HIV, then we need to understand that the most important aspect what we need to see is that we need to address the issue of people's sexual behavior. So that, if we see that, the blood transfusion, that is 90 to 95%, perinatal from mother to child 20 to 40%, but even being the lowest efficient, one of the lowest efficient media, because of only not so responsible behavior, not responsible sexual behavior, actually people are getting, highest number of people are getting the infection. Now, what happens once a person gets infected by HIV? Then that person's immunity system actually gets deteriorated. Once the immunity system depleted, then they get different kind of infections. So that HIV creates a condition where people's immunity condition gets depleted, and because of the low immunity system, they get different kind of infection, and we call it opportunist infection. The infection who takes that opportunity to get into a person's body because that person's defense mechanism of the immunity is low. Now, what are the common opportunist infections are there? Generally what happens that, how do you understand even that one person, or, one person suspects that this person might get that, might have that infection, is that they get a series of infection, those opportunist infection. Then it is suspected that probably this person's immunity is not really working so well, and that is why then they go for the tests, and then probably we see that it might be many other reasons. It might be one of the reasons is that HIV infections. Because of HIV, the immunity system is destroyed or depleted. Now, what are the common infections? Tuberculosis is a very, very common infection. Candidiasis. Candidiasis is a kind of fungal infection. Chronic diarrhea. Then we know herpes. This is a kind of smallpox kind of infection. Toxoplasmosis, this is one parasite. Actually, the main host of this parasite is cat, but it also gets into human body, and it creates problem in the blood cells. That is toxoplasmosis. Then pneumonia, retinitis, and meningitis. These are the common, but there might be many other infections because the immunity power of body is reduced. Then all kind of infections, they get that opportunity and get into human body. But these are the most common infections we find in the infected people of HIV. Now, these are the prevalence. I don't want to get into all these numbers and data, but one thing what we need to understand that the prevalence is actually gradually it is declining. It is showing a declining rate in India, That's a good news. But if you see the declining rate is not that sharp, that it is not sharply declining. It is actually very gradually declining, and the reason is, in most of the cases, what I think is that it is not about the medical factors, not about really the health and medical factors, virology factors. It is the declination is very low because of the cultural aspect, because of the social aspect, because of the behavioral aspect. Because HIV is generally associated with a lot of stigma. Even a person who thinks that who had an unprotected sex, it's a very rare case that that person will actually go for a test and try to understand that whether they got any kind of infection or not. If any person, they understand that they are developing a lot of opportunist infection, even their family members, they really hesitate to go for a testing, because a lot of stigma attached to HIV and AIDS. So that is one of the major aspects, major challenges what we face, not only in India, across the globe. So that for the behavioral and cultural aspects, I would say that actually poses the strongest threat for prevention and treatment of HIV/AIDS. If you look at all these data, you see that it's a gradual declination. Even it is 15 plus, it's the adult population who are living with HIV/AIDS. That is the data. This is again estimated number of new HIV infections. This is important. In 2000, from 2000 to 2011, we see a gradual declination. And at this point of time, if you see that from 2007 to 2011, it's a very, very gradual rate. It's not that sharp. From the beginning, from 2000 to 2006, 2007, it was quite a bit of sharp declination, because that immediate, identifications, the immediate thrust of the kind of programs. But gradually, it is actually getting little bit of not so sharp declination we can see in the graph. Now, if we look at the sex-wise distribution, it's almost the same, 48% and 52%. Male is 52% and female is 48%. These are the new infections among children. So in most of the cases, children, as you know, that it comes from the mothers, but it might get from other sources also. New infections, again, if you see, from of all ages, again, the good news is it is declined, and it is still declining, but the rate of declination has reduced. So it might be that it's because most of the unidentified cases are identified. That might be one reason, so that it is not that sharp declination is showing, but at the same time it might be many other factors. Again, if you see the male-female distribution in new infections, sorry, that's the same thing. New infections among the adult, it is actually the male is 62% and female is 38%. Now, though physiologically, female are more vulnerable to these infections, HIV infections, but male are getting more infections only because of the behavioral aspect, because men are more exposed to the HIV infections. It's because of unprotected sexes. It's because of a lot of migrations, a lot of cultural aspects. So it is actually even though female are more vulnerable physiologically, percentage of male getting the infection is higher than female. Now, state-wise, if you see that prevalent rate is highest in Manipur, followed by Andhra Pradesh, then Mizoram, Nagaland, Karnataka. In fact, the first AIDS case was detected in India in Tamil Nadu. Yeah. And at that point of time, we had a different kind of database, and we actually suspected at that point of time the prevalence rate is very high, but later it was corrected. We rectified the database, NACO rectified the database, and we saw it is not that much prevalent in India, but in some of the states actually it's quite high. Prevalence rate is quite high. And you see that there is a pattern. Like if you see in different states, in all these states, like Manipur, the northeastern states, Manipur, Mizoram, and Nagaland, in most of the cases, this is because of IDUs, injecting drug uses. In other cases, like if you look at Andhra Pradesh and all, it is more sexually transmitted HIVs, because in these cases, human trafficking in Andhra and all these cases, Maharashtra, these states, human trafficking is higher. Unprotected incidences of unprotected sexes, incidences of prostitution is higher, and that is why actually you see a distinct pattern between the northeast states and the southern states. So in northeast states, mainly it is due to IDUs, and in the southern states and other states, western states, it is actually the main source. I am not saying that it is only. The main sources are through sexual transmission. Now, if you look at this, it is quite a bit of concentrated in few population segment. Now, the high risk, you see that there are few high risk groups in the population. IDU, who uses drugs, who inject drugs, it's 7.2% prevalence. MSM, men who have sex with men, they are 7.4%. Female sex workers, they have 5.1%, and who are having STD, sexually transmitted diseases, they are having 3.6%. So there are very clearly few segments in the population who are injecting drug users. They are high risk groups. Men who have sex with men, they are also a high risk group. Female sex workers, they are high risk groups, and STD who are having sexually transmitted diseases, they are also a high risk group for HIV infection. So what we discussed is that we discussed little bit of what is HIV infection and what is AIDS. These are not two same things, HIV and AIDS. AIDS is the consequence of HIV infection. That consequence might happen after a long time, so that one infected person, within the body of an infected person, the infection might actually remain in a dormant stage. It might not really show all the symptoms of HIV, of an AIDS condition, but so that it is really difficult to understand at that situation when these symptoms are not really so understandable, so visible, so much of visible, that whether that person is really infected or not. I mean, apparently at least. And we saw that there is a kind of declining rate of infection, declining rate of in all the age groups, and we saw that there are different transmission routes, and the transmission route or the media which causes more number of infection is the sexual route, but at the same time, sexual route is the most inefficient, one of the most inefficient route for transmitting HIV virus. But at the same time, because of the behavioral aspects, because of unprotected sex, it is contributing the most in the transmission number. Now we saw that we have different, in different states, we have different kind of, prevalent rates. Especially in the Northeast, we see there's a trend, there's a pattern that it is mostly infected through IDUs, and in the Southern and in the West and in all other states, it is mostly about sexual transmission. And there are again social, cultural and behavioral aspects responsible for that. Now, we saw that actually it is a concentrated epidemic in India, so that we can identify few high risk groups, in our population, who are injecting drug users, who are the men who have sex with men, female sex workers, and who have STD infections, sexually transmitted diseases. They are most vulnerable for HIV infection. Now with that, we will get into the discussion of the National AIDS Control Program, different milestones. From starting from 1999, there is a small typo, it should be 1999. To 1992, there is a kind of medium term plan. I'm not getting into all these details of the program. We'll focus more on the recent program. Then if we see that NACP-I, NACP-II, NACP-III, and now we are in NACP-IV. NACP-IV is covering 2012 to 2017. Now in 2007, in NACP-III, in just the previous phase of National AIDS Control Program, we saw that there is a huge scaling up of HIV prevention interventions for high risk groups and general population, and integrate them with a care, support and treatment services. Now this is very important aspect. Now it is not only testing, it is not only treatment of that particular person, but also care and support is very much essential element of the whole continuum of healthcare for these HIV infected people. Because one thing is very, very important, whether that person is infected and then they are getting medical treatment for reducing the infection or increasing the immunity or not, but at the same time that person faces a lot of social stigma in the family and in the society, and because of that, that person actually, first of all, they don't seek treatment, proper treatment, they don't continue treatment, and the second thing is that they need a lot of physical, emotional and psychological and social care, supportive system. In most of the cases, people because they have that misbelief that through different that person can actually spread HIV in different ways. So in many times we see that the family, the community, they really don't take care of the patient, and that causes a lot of problem for the patient. And not only the patient, because of that person might actually get into such behaviors or such pattern that intendedly that person might actually spread HIV viruses more in the society. So a person, first of all, they need human care. They are also human being. This is not a sin. This is something cannot be transmitted so easily. There are distinct transmissions route. We understood what are the routes. So if we are actually protected, we really take care of ourselves. It is very difficult to get HIV infections. It's very, very difficult. It's easier to get any flu. It is easier to get TB. It is easier to get malaria, anything else, because it is not under your control. But HIV infection is something what really you can protect yourself, and it is not so easy to get infected by HIV infection. And that is why we don't need to show any kind of discrimination or stigma to the people who are infected, and really they need proper care. It is not only medical care, but they need the care of the family, they need the care of the community, and they have every right to live a normal life as any other human being. So that is very, very important aspect, and NACP-III actually integrated all these care and support elements with the medical approach to the epidemic. Now, the recent program, the NACP-IV, what are the objectives? Reduce new infections by 50% based on the 2007 baseline of NACP-III. Objective 2 is comprehensive care, support and treatment to all persons living with HIV/AIDS. So this is called, again, talking about emphasizing on comprehensive care. So it is not only treatment, it is not only identifying infection and treatment, it is also about holistic support to that person. So they should not face any discrimination at family, they should not face any discrimination at workplace. A child, infected child, should not face any discrimination at the school or in the peer group. So it's a holistic support is required to address this epidemic. It is again, just to note that it is not about that person. If we take proper care of this person and if we really don't discriminate them, then actually we can reduce the stigma, and it might actually help us to spread the infection further. Now, what are the key strategies under NACP-IV, National AIDS Control Program? 4 is intensify and consolidate preventive services, increase access and promote comprehensive care, support and treatment. Expanding IEC services. IEC is information, education, and communication services. That is one of the most important things, so that we can sensitize people and we can reduce the stigma about HIV/AIDS and misbeliefs about HIV/AIDS. Capacity building, strengthening strategic information management system. So these are the key areas which is being focused through NACP-IV. In NACP-IV, the key priority areas are preventing new infections, prevention of parent-to-child transmission, focusing on IEC. IEC, again, I said information, education, and communication strategies for behavior change. So it has a very, very important focus on behavior change in high-risk group, awareness among general population, and demand generation for HIV services. Now, if you see that in HIV, one of the most important aspects, because the sexual transmission is one of the largest transmitting media, is safe sex, because this is something, we call it risk minimization strategy, so that if it is not to stigmatize sex or sexual behavior, it is saying that, have sex responsibly, have sex safely. So, it's very difficult to really change sexual behavior of people, but at the same time, what you can do is that you can actually make it a little more safer for people so that they don't get the infection. So that is one of the big behavior change. I mean, it is easy to discuss, but these behavior change of these behaviors are really, really difficult, and it takes a lot of time and a lot of strategic interventions. Then providing comprehensive care, support, and treatment to eligible people living with HIV. PL-HIV is people living with HIV. Integrating HIV services with health system in a phased manner. Now, the new initiative, what was not in the previous initiative, what was included in NACP-IV is scale up of programs to target key vulnerabilities, establishment of metro blood banks and plasma fractionation centers, scale up of opioid substitution. This is opioid substitution is like, in case of the drug users, they take substances like heroin and other substances which are actually illegal, but that can be substituted by little medically safer drugs, and gradually they can actually get rehabilitated through these drug treatment, and that is called as substitute opioids. So these are the same kind of drugs, the same kind of impacts initially they might have, but these are medically safer and these are legal drugs what are actually used by medical practitioners to get one person out of substance dependency. Now, providing then scale up of strengthening of migrant interventions at source, transit, and destination. As you can understand, the migrant population, they are more vulnerable to these infections, so that whether we can have a continuum of services from the sources, transit, and destination. Female condom program, again, there is a kind of gender, there's a kind of differential across the gender line, because in most of the cases, if you for example, the female sex workers, that how many female sex workers will have that decision making power that whether they will have a protected sex or not. In most of the cases, the male customers or the male who goes for having sex with these female sex workers, they will decide whether they will have the protection or not. So in these cases, actually for female, even at household, in case of an infected person, even that person probably doesn't know what the person knows, whether his wife, we can decide whether they can have a sexual, safe sexual, relationship or not. So that to empower women to protect themselves from this infection, one of the most important tool is that female condoms. So that this is actually being promoted so that female can protect themselves from this infections. Then scale up second line of ART. ART is that antiretroviral treatment. So this is, we will be discussing little later that these are the treatments actually we can do so that the immunity system actually gets strengthened, so that the person who is infected, they can fight against the infections little more efficiently, more effectively. But again, whether that can kill the HIV/AIDS or not, that's a different aspect. But it can increase the immunity power of a person who can actually minimize the impact of HIVs, minimize the infection, so that the immunity actually gets stronger to fight different infections. Now, different packages of services. I will take another 5 minutes, then we'll have the break. Provided under NACP, again, I mean, this is almost the same thing. I will not get into detail of this. Again, if you see that prevention, care, support, and treatment, these are the major components of the program approach. So it is not only medical care and identifying the infections, but at the same time, prevention is very important through behavior change, through reducing stigma and discrimination, and also care and support of infected people. Now, there are different kind of two different approaches to these interventions. One is that targeted intervention, that is actually targeted to the high risk groups and the breach population. Who are the high risk groups? As we discussed, that the injecting drug users, the female sex workers, these are the high risk groups. And who are the breach populations? Like the truckers, the migrants, who can actually breach between the high risk groups and the non high risk groups, so that they can sort of act as the transporter of these infections. So these are the breach population. So the targeted intervention, they aim at the high risk groups and the breach populations. So that one is that in the high risk group, we do all kind of things to see that they don't get, again, the prevention, and then once it is detected that a person is infected, then what kind of support we will have to provide to that person. And for the breach population, mainly it is to prevent them from infection. Now, targeted interventions provide services such as behavior change communications, condom promotion, clean needle and syringe for people who inject drugs, STI care, referral to HIV. Now, if you look at this, again, in HIV/AIDS program, we really cannot afford to address the issue of drug dependency. What we are saying is that we are trying to make it little safer. We are trying to protect them from infection, so that it is, again, risk minimization approach. It is not real, it is not that we want to stop through this HIV/AIDS program. Now, that's a different approach, that we should work for drug de-addictions and all. But through HIV/AIDS, what we try to do is that we try to minimize the risk of infections. We try to minimize the risk of infection through drug uses, needle exchanges, through sexual behaviors. What are the preventive cares we can take so that we can minimize that. So that this is called risk minimization effort. There are different link worker schemes. This is another aspect, so that we spread the awareness and sensitization. As I said, that it is not only knowing about the infection, knowing about the condition, but at the same time, it to address the social and cultural stigma, misbeliefs, and also our behavior toward our discriminative behavior toward the patients and the infected persons. As I said, that this is again prevention and treatment of RTI and STI. This is again sexually transmitted and reproductive transmitted infections. The counselors are provided to. So these are the people who actually are most vulnerable, who have, as we said, that who have sexually transmitted infections. So another targeted approach to them, so that we can actually reduce the infection or prevent the infection in these high risk groups. I'll take just one more minute to close HIV/AIDS. Then after the break we'll get into to discuss tuberculosis. So blood safety is another aspect. Definitely, as we discussed, that this could be a potential media of blood for HIV transmission. Condom promotion we have already discussed. So these are all very, very key aspects of NACP-IV, National AIDS Control Program 4. This is HIV/AIDS, HIV treatment services at the kind of hierarchy we have in government institution. Now this antiretroviral treatment, we see that the in 2005 to 2012 the kind of scale up has been done from 2005 to 2012. So what we see is that gradually more and more infected people are actually getting into the antiretroviral therapy or treatment. In 2005 to 2012, again, this is this is about the children. So more and more, what we are trying to do is that we are trying to get more and more people get into this treatment of antiretroviral therapy. Now, one thing you must have, I just wanted to mention this. You must have heard of CD4. This is CD4 is what happens is that when you some person gets HIV infection, their immunity gets reduced. So what happens is that in the immunity cell there is something called CD4. This is a glycoprotein, which is actually a white blood cell that gets destroyed. So that what happens is that with HIV/AIDS patients, the CD4 count get reduced. So lesser the CD4 count, they are more vulnerable to any infection. So one of the purpose for ART, antiretroviral therapy or treatment, is to actually increase the CD4 so that they can fight against the infections and get lesser number of those opportunistic infections. So that is what in nutshell about what we wanted to discuss about HIV/AIDS. And definitely, as usually, if you have any more questions about HIV/AIDS, I would be happy to answer those questions end of the session today. For now, we'll take a 5 minutes break and we'll come back at 12 o'clock. Okay, so I hope you all are back. Now we'll start to have the discussion on tuberculosis. Right now in the break, I was having a discussion with one of the most experienced person I know who has worked in HIV/AIDS and tuberculosis and all these things. One of my good friends and who is also team member of at CSO Partners who works with me. Is that in most of the cases what we do is we create a lot of we mystify this subject so much that we use a lot of jargons, we use a lot of terminologies. The first challenge is that how do we demystify all these aspects? And then, because if we are talking about all these things, it is not that we are having a webinar, it is actually in the same language. It should be explained to a person who is not even educated, because as it is my body and an uneducated person's body, these are the same bodies, and once we get infected, both of us in the same status, so that we should have the common language. So that one of the challenge probably I would request you to please keep in your mind whenever you are having an intervention, when you are having a program, developing an approach, please try to do one thing. Try to demystify all these things and speak in people's language, so that our program would be most effective and efficient program. When we talk about, say, we are talking about we are having a discussions with a mother, and we are explaining her that how she can prevent herself from any infection or prevent her child to get any infection. And if we cannot actually speak in her language, then we are the worst professionals to really work with her, right? So sometimes what we do is that to create a kind of notion that the professionals know something much more than the clients, and that is why actually people look up to the professionals to have the services, and it's a kind of false ego. We protect ourselves by using and creating all this kind of mystery around the subjects we do. So with that, we'll start the session on tuberculosis. Now, what is TB? Again, let us have the discussion. So, if we can translate it in a language where actually a common man, a common person can understand, that is what the success is. An infectious disease caused by Mycobacterium tuberculosis, as all of you know, most common site in the lungs, that is called pulmonary TB. Other parts may be affected, leading to extrapulmonary TB. So one is related to lung, another is not related to lung. It spreads through air. That is the most dangerous thing in this. Cough, sneeze, or a person suffering from disease and excreting the bacteria, also called sputum positive case. One untreated smear positive case, so one person's sputum what carries the bacteria can infect 10 to 15 others per year. So that if I am having tuberculosis and through my sputum I am in a condition where through my sputum I can spread bacteria, so I will actually infect 10 to 15 more people in a year. Again, as we discussed about HIV/AIDS, that I am infected, that does not mean that I am in that condition where actually the symptoms are visible. So that there is a difference between infection and that particular condition of TB, tuberculosis. Once infected, they will stay infected. 40% of India is infected. So that 40% of our population, Indian population, are infected, and maybe many of us who are joining this webinar might be infected. But at the same time, whether we will develop all these symptoms, probably 90% of us will not develop the symptoms, because that will remain in dormant stage and also due to our immunity. So we are all exposed, many of us are infected, but at the same time we will not develop the condition. 90% of us might not develop the conditions. So that Again, 90% of HIV positive individuals, will get into this discussion, and that is very, very important to understand. 90% of HIV positive individuals infected with TB do not develop the disease. So that one is the state of infection, the another state is disease. As I said, that if we are infected, 90% of us might not develop the disease. Now, what are the symptoms? We know all these symptoms: cough with expectoration, more than 3 weeks, fever, night sweats, weight loss, loss of appetite, anemia. These are all symptoms of TB. We know generally nowadays it's very common sense that we know that if one of these symptoms are visible, then somebody should go for a checkup. Now, as I said, that TB infection is not TB disease. So one might get the infection, but it might not develop the disease. When we develop the disease, when our immunity is low, so that we cannot prevent that condition, we cannot suppress that bacteria, then we develop the disease as any other infections. Now, what are the diagnostic tools? The main tool for diagnosis is sputum smear microscopy. As we know that we take sputum, and then through microscope we can find out the bacteria. Then X-ray confirms that. X-ray is a supportive tool for diagnosis. We can see that it is a pulmonary TB or not. Method for diagnostic of EP-TB depend on system that is affected. EP is that extrapulmonary. So what we discussed is methods of diagnosis of EP, extrapulmonary TB, depend on the system that is affected. It might be a bone TB, it might be some other TB. So definitely it might not actually come through the X-ray of chest. So then to confirm that, it might actually require some other tests. Now let us look at that. This is really shocking. 2 billion infected globally. That is 1 in 3 of global population is infected. Again, infected does not mean that they have developed the disease or all of them will develop the disease. 8.9 million new cases in 2004, 80% in 22 high burden countries. So in 22 countries, we have 80% of the cases globally. Now, let's jump to if you look at all these rates are all actually TB infection prevalence. Now, if you look at India's situation, if we jump into that, India contributes to 20% of TB burden globally. So that the total number of TB incidences in world at any point of time, Indians will constitute 20% of that. That is the kind of situation, and that is why we thought that we should have a discussion on tuberculosis, because if any of you are working on health aspect, these are the issues, what we have discussed in terms of, malnutrition, mother and child health, HIV/AIDS, TB. These are probably some unavoidable issues, and wherever we work, whatever the health aspects we work, even if we work on education, some of these aspects should be integrated in other programs also. So if you are doing a livelihood program, you are working with self-help groups or any other groups, farmers group, these are the essential information, and these are the essential components should be integrated in all other programs, because this is one, again, if you look at the community, if you look at the society like we, if our health is affected, definitely many other things would be affected. Our family relationship would be affected, our financial condition would be affected, our educational status would be affected. So it is very difficult to separate these aspects from one to another, so that if we really want to address one of those aspects like education or anything, then we will have to integrate some of the other aspects who are actually the key factors for these particular aspects. So that, as we have seen, that India is contributing 20% of the incidences at global level. Now in India, just if you look at the red letters, 370,000 deaths due to TB each year. So 3,70,000 deaths we are having only because of simple infection called tuberculosis, which is absolutely treatable. The treatment is really easy, and there is nothing difficult for that treatment, other than the behavioral and cultural aspects. But still we are having 3,70,000 people dying due to TB. 20,000 people get infected with TB in 1 year. 5,000 develop TB. 20,000 people are infected, and out of them 5,000 will actually develop the disease. Over 1,000 deaths a day. So if you say that 370,000 a year, that means over 1,000 people are dying due to TB in India in 1 day. 2 deaths every 3 minutes. Again, if we really divide it by how many minutes in a day, then we see that we are losing 2 persons in India in every 3 minutes due to TB. So that is why it's a simple infection, but if you see that the kind of threat it is posing to our developmental goals, it's a really huge threat. So that this is one of the main aspects probably we would like to consider while we will be developing our programs. This is again, whenever you get time, I will be sharing this slide so that you can actually go through these numbers. Now, again, if you compare TB, tuberculosis with other diseases in India, you see that the biggest killer infection in India is tuberculosis. It is much higher than measles, HIV, tetanus, sexually transmitted diseases, tropical diseases, malaria. It's much higher than that. Now, if you look at globally, this is the leading killer among women. So that most number of women are dying of nothing but tuberculosis. Globally, it is not only in India. It then might be concentration in India, as we have seen that 20% of the incidents, the burden we are contributing to. And few other countries, 22 countries are contributing 80% of the total burden. So that there might be concentration, but globally we see that TB is the biggest killer for women. Now, if we try to monetize all these losses due to tuberculosis, one particular infection what we are having, indirect cost to society is $3 billion. Direct cost to society, these are approximate estimations, $3 billion. Productive work days lost due to TB illness, $100 million. Productive work days lost due to TB deaths, 1.3 billion work days due to death. School dropouts due to parental TB, 300,000. So that parents, one of the parents or both the parents are having infection or the TB disease, in fact, the disease of TB, they have developed the disease definitely. 300,000 school dropouts. Women rejected by families due to TB, 100,000. So that in India, whatever the economic growth and India is shining or whatever we see, the paradox is that one, we are having all these infections, all these really bad health status. On the other hand, we see this kind of discrimination against the victims. Again, they are victimized because they are having the infection. So 100,000 families, they reject their women, family member because of TB infection. So this is the kind of situation. As you know that in India, even in big cities, we see still now we have a lot of stigma and discrimination, misbeliefs around TB. It is not only HIV/AIDS. Even TB, we immediately see that people get little, suspicious. People don't want to really get along with them. They don't want to mix with them. They don't want to work with them. So, first of all, we need to understand that 40% of Indians are in any case infected, right? And we are very much exposed. One way we are exposed, that is good, because we have that defense mechanism. We know exactly our body system recognize that particular enemy so that we can defend it in much better way. But we have still social and cultural stigma and misbeliefs and this kind of discrimination against the victims. Now, as many other targeted programs, we have a TB control program in India. You know, through different years that has evolved, and now we are having RNTCP. This is called Revised National Tuberculosis Control Program. So we used to have NTP, National Tuberculosis Program. Then we have Revised National Tuberculosis Program, Tuberculosis Control Program. So this is called RNTCP. Now again, as we are discussing for each of the issues, we are also discussing the government program, government intervention, and these are the macro level programs. We are discussing that because these are the major programs, and probably when we will be developing our program approaches, we should try to see, understand what are the program gaps, what are the areas we can complement to those programs, what are the areas we can supplement to those programs, so that we can create a meaningful impact and long-lasting impact. So to understand RNTCP, the objective is to achieve and maintain a cure rate of at least 85% among newly detected infections, and then to achieve and maintain detection of at least 70% of such cases in the population. So these are the two very strong objectives we have. One is that to achieve and maintain a cure rate of at least 85%. So that we are saying that we should have 85% of cure rate and a detection rate of 70%. So that detecting infection by 75% and cure of infected person by 85%. These are the two clear-cut objectives we have. Now, what are the unique features? District TB Control Society. So it is very much decentralized, modular training. So it is a kind of very, the TB workers, the health workers who are actually working in this particular program. And also, as I said, that these are all converged into the major health program we are having. So that there is a kind of modular training, patient-wise boxes, sub-district level supervisory staff, so that it is not at only the district level, sub-district level, robust reporting and recording system. And as you know that, in most of the cases, and most of you might be knowing that now we are having DOT program. That is another main feature of the recent approaches against TB. DOT is direct, directly observe treatment. So that what we are doing is, again, is very simple. What we are trying to see is that that patient is taking that particular medicine, and we are making sure, because we are observing that in front of the health worker, the patient is having the medicine in a regular manner, in the due course and in the full course, so that there is no dropout, there is no really so once what happens is that in most of the cases, there might be little bit of side effects, there might be little bit of discomforts with when taking this, and there might be misbeliefs also around these medicines. But what happens once they stop taking this medicine without completing the full course, that person might get resistance against that particular that drug. I mean that particular bacteria in that person might get resistant toward that particular medicine. So then it becomes really difficult, because the medicines, once this get resistant to that particular medicines, then you will have to go for multi-drug treatment. It might get into multi-drug treatment resistant. It would be very expensive treatment for that person. And one country like India, as you can understand, it would be really difficult to address that issue. And one of the major issue across the world is that multi-drug resistant tuberculosis. So that this bacteria is getting mutated, and it is getting actually developing its resistance, its development, defense mechanism against different drug systems. The impact of RNTCP: cure rate more than doubled compared with the earlier NTP. 85% global target consistently achieved. The global target was actually 85% for cure rate. It is being achieved since 2003. Case detection rate is close to global target of 70%. Detection rate is 70%. But the big question is that why then still we are having so much of infection? It is because the spread of infection is so high. It's much higher than the detection and the treatment. Case fatality reduced from 29% to 4%, so that deaths due to TB infection has been reduced from 29% to 4%. Over 6.3 million patients initiated on DOTS. I told you what DOTS is, and over 1.1 million additional lives saved. Now, this is the organizational structure. If you are really developing some kind of program, you need to understand the organizational structure of this government program. So, I will leave these slides with you. You can have these slides and have a look at that once it is required. If you really want to see that at what level, what kind of coordination and what kind of synchronization you want to develop for your intervention program. Now, as we discussed about HIV and TB, now another very, very big challenge is that burden of co-infection. As we said, that TB is one of the most common opportunist infection for HIV/AIDS patients. Now, once it gets together, that actually poses a really much bigger threat than HIV or TB alone. So, together TB and HIV actually in recent days has created a much bigger threat than those individual diseases. In 2005, we had 40.3 million people living with HIV/AIDS in the world. I mean, there's the 2005 infected people we are talking about. Globally, 1/3 of all PLHs are co-infected with TB. In India, more than 50% of AIDS cases reported so far has developed TB. So disease, it is not about infection. So as we said that once the immunity is low due to HIV infection, this opportunist infection they develop disease. So like you and me can have the infection, but we are not developing the disease because we have a strong immunity system. So we are suppressing that infection. But HIV patients, as we discussed, infected persons, as we discussed, that they will have low immunity power. That is why once they get the infection, they develop the disease. 5% of the adult TB cases are HIV positive. So amongst all the TB cases, 5% are HIV positive. In India, more than 10 lakhs people are suffering from TB-HIV co-infection. Now, what are the effects of AIDS on TB? Risk of developing TB is higher. Definitely, as we discussed, that once the immunity is low, definitely, developing any kind of disease is much higher. Infectious disease. Rate of progression from infection is 10 to 30 times higher. So progression means the rate from infection to the disease, developing disease from infection is 10 to 30 times higher than a normal, a person who is not having HIV infections. TB is the most common opportunist infection that we have already discussed, increases the rate of progression from HIV infection to AIDS. So what happens is that, it's a kind of vicious cycle. Because of HIV, immunity is low, one person develops TB disease. Because of the TB disease, again, the progression of HIV infection to, AIDS is much higher. So, one is contributing to another, and that's a big threat for, the person who are infected both with AIDS and TB. So that what happens is that once HIV infected person gets TB, it is not only that the transmission rate from TB, the progression rate from TB to TB disease, infection to disease is higher. At the same time, TB again lower the immunity system and spreads the HIV, at a much higher level. So that what happens is that the HIV infected person gets into the AIDS condition, acute immunodeficiency syndrome condition, in a faster way. So it is contributing, one is contributing to other, and strengthening other and weakening that person's health condition. So that is the kind of co-infection duality we find if HIV and TB are infect a people together. Shortens the lifespan of patients with HIV infection. Definitely we can see that it would shorten. Common cause of death is in AIDS patients. Now, as we discussed that AIDS by itself does not kill, right? What happens is that it reduces the immunity, then it gets opportunistic infections, and due to the opportunistic infections the person dies. So which opportunistic infection is killing HIV infected people the most? That is TB, tuberculosis. Now this is the kind of effects of TB on AIDS. Immune response to TB bacilli, increase in HIV replication, so that it is the virus is getting replicated, 6 to 7 folds increase in viral load, rapid decline in CD4 count. I told you about CD4. This is a glycoprotein. This is actually a white blood cell which is responsible for our strengthening our immunity system. Increased risk of developing other opportunistic infection. So that is the kind of impact of TB on HIV and HIV on TB. Now, as we talked about DOTS, directly observed treatments, it is again very helpful for the person who is HIV infected. At the same time they get the opportunistic infection of tuberculosis. So DOTS can prolong life and improve its quality. As what we are doing is that it's simply, again, there is no rocket science in this. What we are doing is that we are controlling the infection of tuberculosis, so that definitely it will prolong the life. Lifespan increases by an average of 2 years. DOTS is equally effective in HIV infected person as in general. So that if I get tuberculosis, if I develop tuberculosis disease and one HIV infected person develops the disease, it would be equally effective. The DOTS treatment would be equally effective to that infected person and to me also. Confidentiality is maintained while administering, because the health workers, they administered that to the TB patients. It might be TB without HIV, TB with HIV. The health persons are trained to maintain the confidentiality. Failure to use DOTS in the face of HIV infection can lead to worsening of the TB epidemic. So that what we discussed today, we discussed about HIV/AIDS. We discussed about tuberculosis. In HIV/AIDS, we saw that one of the most the media which is contributing to HIV infection the most is the sexual media and unprotected sexes. Through what actually it is, though unprotected sex is one of the weakest media, but it is actually contributing to HIV. So that we need to understand that health aspects has a very strong behavioral element. If whether it is nutrition, whether it is mother and child care, whether it is HIV/AIDS, whether it is tuberculosis, so that the takeaway of the day is that health is not only the medical issues. It is not about the medical treatment and the clinical treatment and the doctors and the medicines, but it has a lot of social, cultural and behavioral aspect. And when we were developing the programs, when we design our programs, we need to understand that probably most of these infections can be prevented by behavior change only. Yeah. Or most of these health issues can be addressed by behavior change only. Like, if I talk about malnutrition, we saw that there are a lot of behavior aspects. Even there is service, available through the government health machinery. but whether we are accessing those services or not, that is important. And accessing services is a behavior, whether we are going, whether we are seeking health support or not, health services or not, health seeking behavior. So that we see that, in most of the cases, what happens is that most of the corporates, again, I don't want to really disrespect anybody, but it is not about having mobile clinics, it is not having, weekly clinics or monthly clinics. But if we really are serious about addressing these health issues, and if we really want the return of investment, we are making in health sector, then probably what we'll have to do is that we'll have to, integrate the behavioral aspect in the program, in our health programs. Now, these behavioral aspects in most of the cases are the most difficult aspect to really address. It is a very long-term change what we see. It is not always so much of visible, as apparently visible as in any other things. It is not developing an infrastructure or, distributing medicine or, distributing any other things. So what happens is that once we develop this health, behavioral aspects, definitely we'll have to have a long-term project cycle so that we can actually work in a meaningful manner with people, and we see some of these changes to happen, through our programs. So with that, I will open the forum for question. And if you have any question, please let me know. So I'll try to address your questions. And okay, Miss Prativa Kulkarni, she is asking that educating an awareness program on AIDS or TB will be considered as CSR activity or not? Yeah, that definitely will be considered as CSR activities. If you remember that I had mentioned about a High Court verdict, Delhi High Court verdict, because in the act, it was only about preventive health. Whatever you do in the health sector, according to the verdict, actually that can be covered. So that many people had the concern that whether we have a hospital or treatment or the clinics and other things, whether that would be covered or not. Now it is actually a comprehensive healthcare that could be covered. So definitely sensitization, any preventive approaches, awareness generation, that would be covered as CSR expenditure. What I would say is that, see, sometimes what we do is that we print few few materials, we develop some materials, we post some ads and all these things, and we think that will lead to behavior change. Again, behavior change is, we'll have to have a scientific approach toward behavior change. So, we need to understand, first of all, behavior again is a manifestation. That manifestation comes from, our learning through childhood, what we believe, what we learn, what kind of transactions we do to the environment. So that each behavior, if you really want to have a behavior change program, then you will have to do it in a proper manner, so that each behavior has to be analyzed, that why this behavior manifestation is there, and then try to see that how do you go to the root cause and address that, so that whether it is only knowledge, like for example, if I am a smoker, and you are informing me that smoking is bad for your health. I know it is bad for your health, yeah, but I still smoke, right? So that information is not enough. Then what is there? How do you want to change that attitude? Do I have a negative attitude toward smoking? I have, right? But still it is not translated into my behavior. Do I want my child to smoke? No. I have a negative attitude, but still my behavior of smoking is not changed. So what I'm trying to say is that definitely these awareness, sensitization and all these things are very, very welcome activities. But at the same time, I would say that again, you will have to get into a little deeper and try to understand that how do we actually get into a behavior change program? Yeah, it is not only giving information. Then as per Schedule 7 under promoting healthcare, can we take HIV/AIDS and TB awareness programs? And the same question, yes, I have already answered this. Could you please give some examples as to how a corporate can design a program so that it's eligible for CSR and also it meets the common objective? Yeah, definitely I will do that, Mr. Winston. When I will be actually having sessions specifically for program planning, program designing, then I will actually discuss it in a more in-depth manner. So yeah, definitely I will give examples and I will have more discussions about that. As you have noticed that I always actually try to say that program should be designed. A program should be developed in a proper manner so that it based on a proper analysis, assessment, and then you design your interventions so that you can address the root causes of that symptom. Like in many cases, what happens that, as I always give that example of health clinic and all. Now what you are doing is that you are actually, we are fumbling around the symptoms. We are not really addressing the root causes. So that is why if we actually design that program in a proper manner, our return of those interventions of the programs would be much higher. Anyway, I will be discussing all these things in much more in-depth manner. So please keep patience till that time. So any other question if you have? Listen. Just wait for a few seconds. Actually, I'm having I'm a little confused with this dashboard. It has become all of a sudden smaller. I'm trying to get the dashboard back. I got it back. Thank you. So can you please share any web link where we can get details of the people affected? See, all the authentic data would be on the NACO sites, National AIDS Control Organization. That is the India government site. They only actually manage the data. They only manage all the programs in AIDS. So that if you get into NACO site, NACO, National AIDS Control Organization, Mr. Winston, you will get all the data, whatever is available, all the reports, data, and that is the only source of authentic data, I would say. Yeah. Could you please give some examples as to how to corporate can design? We have already discussed that. Educating awareness is well considered, we discussed. Okay, it looks like I'm not getting more question. If you don't have any question, today we will close the session little earlier than the usual time. And definitely, if you think of any question, please you write to me. I will try to actually answer those questions. Okay then. So thank you so much. So next session we'll be having on livelihood issues. Thank you so much.